Okay, so let's unpack this. If you follow medical news, the clinical guidelines, they usually just tweak a dosage here or maybe add a footnote there.
Yeah, it's rarely a massive overhaul.
Right. But every once in a while, something drops that completely rewrites the playbook.
Okay.
And in today's deep dive, we are looking at the February 2026 NDE update to Type 2 Diabetes Management, NG28.
And honestly, it's being called the most significant shakeup in over a decade. We aren't just adjusting targets anymore. We are fundamentally changing the philosophy of care.
The whole mission has shifted. Because for years, the model was glucose-centric, right?
Exactly. The entire mission was just chasing that HbA1c number, getting the sugar down. But NG28 moves us toward cardiorenal protection.
Which is a massive conceptual shift. We're moving from treating a number on a lab report to essentially treating survival, specifically protecting the heart and kidneys regardless of what the glucose meter actually says.
It's a shift from reactive treatment to proactive organ protection. We aren't waiting for the complications to show up anymore.
Right. And the biggest headline change here is the death of the metformin-only start. For a long time, the standard advice for a new diagnosis was start with metformin.
Just see how it goes. Yeah, it's officially over.
The new standard for most adults is dual therapy right from the moment of diagnosis.
We are talking about modified release metformin paired immediately with an SGLT2 inhibitor, the flawzins.
Modified release to handle the stomach issues better and the SGLT2 inhibitor to protect the organs. And looking at the sources, there's a clear economic driver here too. The availability of generic options like dapagliflozin makes this incredibly cost-effective now. They're projecting this could save the NHS around £560 million.
The economics certainly make the decision easier for the system, but for the patient, the why is strictly clinical. We have a mountain of evidence now showing that SGLT2 inhibitors reduce heart failure admissions, slow down the progression of kidney disease, and lower cardiovascular mortality.
And here's the kicker.
They do a lot of this independent of your glucose levels.
That is the part that always gets me. You could have your blood sugar perfectly under control, but without the SGLT2, you're missing out on this vital armor for your heart and kidneys. Now that's the standard path, but the guidelines get even more aggressive if you have a patient who already has established cardiovascular disease.
Then you move immediately to triple therapy. If you have established atherosclerotic cardiovascular disease, or ASCVD NICE, is pushing for metformin, an SGLT2, plus a GLP-1 receptor agonist like semaglutide right out of the gate.
Hitting the pathology from 3 different angles immediately, it seems like they're taking a similarly aggressive stance for younger patients too.
They are. If you are diagnosed under 40, or if you're living with obesity, the guidance suggests considering GLP-1s or even tirzepatide very early on.
Because if you're diagnosed at 30, you have decades of metabolic risk ahead of you. You don't have the luxury of the slow and steady escalation we used to do.
Precisely. The lifetime risk of complications is much higher, so the treatment needs to match that risk profile immediately.
We should also briefly mention the equity side of this, right? Because historically, SGLT2s have been underprescribed to women, to Black patients, and to older adults. Closing those gaps is a huge part of this update.
Absolutely. Everyone needs equitable access to these protective benefits.
But there is a trade-off here. We're handing patients a powerful cocktail of drugs on day one. And specifically with the SGLT2 inhibitors, there's a safety protocol that seems absolutely critical to understand.
This is the non-negotiable part. If you're putting more people on SGLT2 inhibitors, you have to teach sick day rules. Because the drug changes how your kidneys handle sugar and fluids if a patient gets acutely ill.
Like vomiting or a fever.
Exactly. Vomiting, fever, diarrhea. They must stop taking the SGLT2 inhibitor temporarily.
And if they don't?
You risk acute kidney injury and something called euglycemic diabetic ketoacidosis, or DKA.
And euglycemic is the tricky word there because it means their blood sugar looks normal.
That's the danger. You can't rely on the glucometer to warn you. Your sugar might be fine, but your blood chemistry is becoming dangerously acidic. It requires patients to be very in tune with their bodies. There's also the hygiene aspect, where patients need to stay hydrated and watch out for mycotic infections.
So to recap the mission of this update, we have moved from treating a sugar number to treating the whole person. Weight, heart, kidneys. We are using dual therapy right out of the gate for almost everyone, and triple therapy if the heart is already in trouble.
It is a modern, outcome-driven approach, treating the risks we know are coming rather than waiting for them to arrive.
It's a brave new world for diabetes care. But here is something I want you to think about as we wrap up. If the medication strategy has shifted so aggressively towards survival and organ protection, and these protocols are independent of how you actually feel day to day, How does this change the conversation about patient autonomy?
It's a heavy mental load.
It is. We are asking people to manage complex sick day protocols and infection risks in their daily lives for benefits they might not physically feel for 20 years.
Mm.
That is a heavy burden to carry alongside the diagnosis itself.
That really is the challenge we all have to figure out next.
Thanks for joining us for this deep dive. Take care of yourselves and your kidneys.